My name is Charles Morin. I'm a professor of psychology and director of the Sleep Research Center at Laval University in Quebec City, Canada. It's a great pleasure for me to be with you this morning and to give this lecture on the topic of cognitive behavioral therapy for insomnia, current trends in treatment development and dissemination. Before I start the lecture, I just want to disclose some potential conflicts of interest with the industry, but at the same time I want to mention that none of the material that I will discuss this morning is related to these relationships. So what I would like to do in the next 40-45 minutes is to first talk briefly about the nature and burden of insomnia, and then review some of the evidence about cognitive behavioral therapy, or CBTI, for insomnia, and also talk about some recent trends on treatment delivery and dissemination, and talking about web-based and internet-based applications or dissemination of CBTI. First, insomnia, as you're well aware, is a very significant public health problem. There's a tendency, though, to trivialize this problem, but it's a serious problem. First, it's highly prevalent condition, both as a symptom and a disorder. It's estimated that approximately 10% of the adult population meet criteria for an insomnia disorder. And to this number, we can add another 20-25% who present occasional symptoms of insomnia. So when we say it's prevalent, it's highly prevalent. Insomnia is also often comorbid with another psychiatric, medical, or even with other sleep disorders such as sleep apnea. So in about 50% of the time, there will be a comorbidity, and the most common one will be major depression, generalized anxiety disorders, pain, and if it's another sleep disorder, it could be sleep apnea. The other thing to keep in mind also when we see a patient with insomnia is that the diagnosis of insomnia is based on the patient's subjective complaint of poor sleep or difficulties initiating or maintaining sleep. It's not necessary to have polysomnography to validate the diagnosis. We know that polysomnography is essential for the diagnosis of many other sleep disorders, but in the case of insomnia, it's not recommended in the routine evaluation of insomnia unless you have suspicion of another sleep disorder. Insomnia, there is not just one form of insomnia. There are many different subtypes of insomnia, so it's a very heterogeneous condition. Already I've mentioned that oftentimes it presents with another comorbid disorder, but some patients will also present with a significant level of hyperarousal, which is a core feature of insomnia, but not everyone will present with this feature, as well as not everyone will present with a comorbid psychiatric or medical disorder. So when we say it's a heterogeneous condition, it really is. So if we look at the diagnostic criteria of insomnia, we can refer to those from the DSM-5 or the International Classification of Sleep Disorders. These are highly harmonized criteria. So the first one is dissatisfaction with sleep quality or duration, but there must be also subjective complaints of difficulties initiating or maintaining sleep. And the three classic symptoms of insomnia are problems with falling asleep initially at bedtime, problems with waking up during the middle of the night, or early morning awakenings with an inability to return to sleep. But insomnia is not just a nighttime problem, it's a 24-hour problem. And to make the diagnosis of insomnia disorder, there must be evidence of significant distress or daytime impairments that are associated with the sleep disturbances. And oftentimes it's those daytime impairments, fatigue, decreased energy, mood disturbances, cognitive impairments that will bring patients to a practitioner for treatment. The other criteria to make the diagnosis involves a minimum frequency of 3 nights per week and a minimum duration of 3 months. It doesn't mean we should ignore patients with complaints that are less frequent or of shorter duration. Actually, it's good clinical practice to attend to these complaints before they turn to a chronic problem. With these criteria, we have to say that there has been a significant change in paradigm when making the diagnosis of insomnia, and we no longer need to make a distinction between primary and secondary insomnia. If these criteria are met, then we just make the diagnosis of an insomnia disorder with or without another comorbid condition. And the reason for these changes is simply because too often in the past, clinicians would assume that insomnia was just a symptom of something else, be it major depression or a generalized anxiety disorder. And if you treated adequately these so-called primary condition, the assumption was that they would take care of the sleep problems. But now there's a huge amount of evidence showing that that's not the case in many patients. You may, in a patient who present comorbid insomnia and depression, if you just treat the depression, even if you treat it successfully, the most common residual symptom is sleep problems along with fatigue. And the persistence of these symptoms increase the risk of relapse for the depression. So clearly now the recommendation from most sleep experts is that when you have a patient who present mixed insomnia and depressive symptoms or this depressive disorder or anxiety disorder, that you should treat both conditions and not assume that by treating the so-called primary condition, it will also treat the underlying sleep problems. Insomnia needs to be attended rapidly and not let it linger for months or years because, as we can see on this slide, these are data derived from a large cohort in Canada that we have followed over 10 years. And if you focus your attention to the right-hand side of this slide, we can see how often insomnia persists over time. So we have 3 groups here. The yellow or orange is for the total sample, and we subdivided those people into those who presented a full insomnia disorder or those who presented the insomnia symptoms. But in both cases, we can see that these symptoms are very persistent over time. So of those who presented, of those 100% who presented either insomnia symptom or disorder at baseline, we can see that nearly 3/4 of them continued reporting insomnia a year later, 52% 3 years later, and 5 years later there was still nearly 42% of those who had insomnia at baseline who had reported insomnia at every year of the follow-up. So clearly insomnia is often a very persistent condition, and we need to intervene if we want to stop this vicious cycle. And if we don't, then we may end up with additional problems, because now there's also a huge body of evidence showing that chronic insomnia can bring other problems. For instance, it's been well documented that chronic insomnia increased significantly by 2 or 3-fold the risk to develop major depression, even among people who have no history of prior depression. So clearly this is something to keep in mind, particularly if you would have patients who present comorbid insomnia and depression. There would be a risk to worsen, to see the depression worsen over time. There is also some early evidence showing that chronic insomnia may increase suicidality, that is, suicidal thoughts and so on. So clearly we need to pay attention to insomnia to make sure that people do not develop those other problems. It's the same for medical condition. Chronic insomnia has been associated with increased cardiovascular risk and mortality, and with occupational dysfunctions or impairments. Clearly, people with chronic insomnia often complain of difficulties functioning at work, poor attention, poor concentration, problems with memory, and there's definitely an increased risk of absenteeism and risk of disability among people who have chronic insomnia disorders. Even on the road now, there is, I think, the risk of road accidents has clearly been demonstrated with sleep apnea. And now there are some data suggesting that the fatigue and the lapses in attention often associated with insomnia can increase the risk of errors on the job and accidents on the road. So all this put together should tell us that we need to take insomnia complaints seriously. Now let's move to the treatment options. There are different treatment options available for insomnia. Today I'm going to be focusing mostly on cognitive behavioral therapy, but I'll make some comparisons also with pharmacotherapies, because pharmacotherapy is still the most widely used treatment modality for insomnia, even though the bulk of the evidence is clearly in favor of cognitive behavioral therapy, particularly when we talk about chronic insomnia. But nevertheless, we know that there are different classes of medications available to treat insomnia. The traditional benzodiazepines and the benzodiazepine receptor agonists, such as the zopiclone, zolpidem, zaleplon, and so forth. In some countries, we have melatonin receptor agonists that are available either with or without prescription. Some sedating antidepressants. Among the over-the-counter drugs, the most common active ingredient is a form of antihistamines, and more recently, the new drugs on the market have a different mechanisms of action. These are the orexin antagonists. This is not the goal of my talk this morning. I'm sure you've had many talks on these different drugs for treating insomnia. I'm going to focus mostly on CBTI. But before I do, just to mention that there are also a number of complementary and alternative approaches. I don't know in Colombia, but in Canada they are very popular, and but there's not much evidence to support these so-called complementary and alternative therapies for insomnia. You're surely aware that in the last 5 or 6 years there have been several clinical practice guidelines published for the management of insomnia. And in all those guidelines that were published, the first recommendation is always the same. Cognitive behavioral therapy is the first-line therapy for chronic insomnia. But we have to add the caveat, when it's available. But when all treatment options are available, clearly the evidence suggests that CBTI should be the treatment of choice for chronic insomnia. In those guidelines, also other treatments have been endorsed, for instance, the benzodiazepines and benzodiazepine receptor agonists. So here we talk about temazepam, flurazepam, triazolam, which is probably no longer available in most countries. But there are several other benzodiazepines that are used off-label, such as lorazepam and many others. So these are recommended, but only for short-term use. Some guidelines have also recommended the melatonin receptor agonist, but mostly for older adults. And some have also recommended selected sedating antidepressants. But just as important when we read these guidelines are the treatments that are not endorsed, either due to limited evidence of efficacy or concerns about safety. We know that, I mentioned it, that complementary and alternative medicines are widely used, but there's clearly not enough evidence to support these practices. And actually, you may have experienced that with some of your patients, but oftentimes patients report more adverse effects associated with antihistamines than with other sleep-promoting drugs. I'm not sure again what the practice is in Colombia, but in North America, antipsychotics are widely used for the management of insomnia, even among patients who do not have a comorbid psychiatric or psychotic disorder. So this is clearly not a practice that is supported by the evidence currently available in the literature. Now let's move to CBTI and review what are the key components and treatment targets. So typically when we talk about cognitive behavioral therapy, it involves three major components. As the name implies, there is a behavioral component which will involve typically sleep restriction, stimulus control, and relaxation. There's a cognitive component also that involves a form of cognitive restructuring therapy and paradoxical intention. And then there is an educational component, which is basically some sleep hygiene education. And many clinicians may say or think that they're doing cognitive behavioral therapy when they are telling their patients to stop on caffeine, to exercise more, and to decrease alcohol around bedtime. But this is sleep hygiene education. This is not CBTI. To talk about CBT, we need to do these behaviorally based therapies. With sleep restriction, essentially what we aim is to decrease the amount of time spent in bed. So if a patient typically spends 8 hours in bed but only sleeps 6 of those hours, then the first treatment recommendation will be to compress the sleep window to those 6 hours. And if the sleep efficiency is greater than 85 or 90%, then you increase your time in bed until the patient achieves an adequate sleep duration. If the sleep efficiency is lower than 80%, you decrease the sleep window. So in doing that, you increase the homeostatic sleep drive, and this works very well along what we call stimulus control instructions. These are going to bed only when sleepy at night. There's no point in going to bed at 10 o'clock because it's 10. If you're not sleepy, you should just postpone your bedtime. And if sleep does not come within 15-20 minutes, you should instruct your patients to get out of bed and go back to bed only when sleepy again. To use the bed and bedroom for sleep only. So people who are using their cellular, their iPad, watching television in bed, this is not the place to do that, because this will only strengthen the negative association with sleeplessness. And you rather want your patients to develop new association with this environment. Typically, chronic insomniacs have come to associate that time of the day and that environment with the frustration of being unable to sleep. So you need something to break that vicious cycle, and with the stimulus control instruction, that's exactly intended to do that. Cognitive therapy is a bit more tricky and does require more training to be implemented properly, but essentially you're trying to correct some unrealistic sleep expectations that patients may entertain about their sleep, how much sleep they should get. And some people feel that everything that goes wrong during the day is due to poor sleep at night. Of course, poor sleep may have consequences on daytime functioning, but insomniacs often develop some form of obsessions about their sleep, and this often becomes a vicious cycle. The more you worry about not sleeping well, the more likely you will sleep poorly. And the more you sleep poorly, the more likely you will have an impaired daytime functioning. So you need a specific intervention to break this vicious cycle, and that's exactly what cognitive therapy is intended to do. So I wish I had more time to explain the details of these procedures, but there's a great deal of writing about how to implement cognitive behavioral therapy. Typically or ideally, it's implemented in the context of half a dozen consultation visits. If you want to have enough time to address each of these components, you need to take the time to explain them well to your patients and make sure that he follows the recommendations, because the success of CBTI rests upon the patient's willingness and motivation to implement these recommendations. You can only guide him or her in implementing those, but you cannot do the work for your patient. There are a number of considerations to take into account when selecting a treatment for insomnia, and I've listed some of those here, and I will review some of the evidence-based now that specifically target these questions. First, about the efficacy of CBTI. And so you have here, I've picked two meta-analyses, one fairly recent about the efficacy of CBTI, and another one about the use of drug therapy for insomnia. And whenever we do a meta-analysis, the metric that is used to assess efficacy across all studies, the common metric is an effect size. And typically an effect size of 0.2 is considered small, 0.5 it's medium, and an effect size of 0.8 is considered large. So on the left-hand side of here, you have the effect size associated for different endpoints for CBTI. One endpoint that is widely used is a questionnaire called the Insomnia Severity Index. It's a questionnaire we have developed here in Quebec, and it's now widely used in many studies. And this is what we would normally call also a patient-reported outcome. And you can see that the effect size associated with this measure is quite large. Another one is the Pittsburgh Sleep Quality Index. And then we have all the different variables derived from daily sleep diaries that patients are typically asked to keep throughout the duration of treatment. And you can see that the effect size are quite good for reducing the time to fall asleep, the amount of time awake after sleep onset. Not so good to decrease number of awakenings or to increase total sleep time. And this may come as a surprise to you. If we treat insomnia, how come are we not able to increase total sleep time? Well, oftentimes when you use sleep restriction, one of your recommendations is to decrease the amount of time spent in bed. And it may take several weeks, sometimes a few months, before people can actually increase their sleep time. They improve their sleep efficiency, but the total sleep time will only increase several weeks after the end of treatment. And as a base for comparison, then we can look at the impact of drug therapy on these same variables also derived from sleep diaries. At the top here, These are the variables as measured by polysomnography. So in general, we can see that the impact of drug therapy is less than the impact of CBTI. Although for some variables, such as total sleep time, there may be an advantage to drug therapy. And for sleep efficiency, there's much more variability, as we can see here with the error bar. The other big question is, well, it's one thing to improve sleep over a short period of time, but what happened at the end of treatment? So here again, we have the data from 2 meta-analyses looking at CBTI, and we can see that unlike with drug therapy, the benefits that are obtained with CBTI, they may take longer to, actually a patient may take longer to improve his or her sleep. But once sleep is improved, you can see that these benefits are very well maintained at 6 months follow-up or 12 months follow-up. And that's true for sleep latency, that's true for sleep efficiency, and that's also true on the Insomnia Severity Index that I described earlier. On this slide here, we have the absolute values of these 3 sleep parameters. And we can see once again the value at baseline, post-treatment, and we can see that whatever improvement is achieved at post-treatment, they are well maintained at follow-ups, averaging 6 months in duration. And for total sleep time, as I mentioned before, total sleep time may not improve a great deal right at the end of treatment, but it does continue improving even when we conduct follow-up 6 months later. Now, we used to exclude all patients who had comorbid medical or psychiatric disorders from clinical trials evaluating CBTI. And that doesn't make much sense because the large majority of people we see in clinical practice for insomnia also present another clinical condition that may need attendance. So these are 2 meta-analyses also reporting the impact of CBTI when it presents along with comorbid medical or psychiatric disorders. And we can see that the effect size for the same variables I mentioned before are quite comparable to those that I presented earlier for patients without comorbidity. Or actually, typically in those other meta-analysis, everyone was included, whereas here it's only for those studies that were done with patients with comorbid medical or psychiatric disorders. Now, if we want in a nutshell summarize what are the benefits and limitations of CBTI in comparisons with medication for insomnia. Clearly, both are efficacious in the short term, and the advantage of medication is that it provides rapid symptomatic relief. But the advantage of CBTI for chronic insomnia is that it produces sustained improvements over time, whereas with drug therapy, there is still fairly limited evidence of long-term efficacy. Perhaps with the exception of a few studies looking at the impact of S-zolpidem over 6 and 12 months, and the same for zolpidem. Most of the studies are run over a short period of time, typically only the time necessary to get approval from the health authorities, be it the FDA in the United States, Health Canada in Canada, or similar authorities in other countries. Also, what we can say in terms of advantages for CBTI is that it is generally well accepted, and there are very few adverse effects, perhaps except for the daytime sleepiness that may come initially with sleep restriction. But at the same time, we have to recognize that it does require time and motivation. So clearly, it does require more work than just taking a sleeping pill. So compliance may be a problem, and that's why it's recommended to implement this treatment in the context of several consultation visits, not just give a bunch of instructions to your patient and say, come back to see me in 3 months. That doesn't make any sense for most patients. They will need guidance and support to follow up on your recommendations. But when we do comparative studies of CBTI with drug therapies, we often end up with not having any single treatment that works for all patients. So we have to work, or we have to develop methods that are still more effective for the majority of patients. So I'm just going to summarize the main findings from 3 studies we ran over the last decades or more, looking specifically at the comparative benefits of CBTI versus medication or combined therapies. This was one of the early studies, probably the first studies that directly compared CBT with medication and combined therapies using a placebo-controlled conditions. This was a small study with 76 older adults. Their main complaints was about maintaining sleep. So the main outcome measure was the amount of time awake after sleep onset. So we have the findings here: baseline, post-treatment after 8 weeks. Treatment was implemented in the context of 8 consultation visits with either a psychologist or a psychiatrist, depending on the condition they were assigned to. But what we can see is that, so we have the data at post-treatment, 3 months, 6 months, and no, that's 3, 12, and 24 months follow-up. And we can see that all 3 active treatments, here the medication was in benzodiazepines. It was temazepam, which is an intermediate half-life benzodiazepines, which we felt was the best available for sleep maintenance problems. We have to go back here now, nearly 20 years ago. But what we can see here is that all 3 active treatments were quite effective to decrease the amount of wake time after sleep onset initially during the initial treatment. And they were all more effective than the placebo conditions. But it's those who receive CBT who retain their initial benefits best over time, whereas those who were treated with medication alone, they essentially went back to their baseline status by the time we did the 24-month follow-up. So even if medication may be useful initially, clearly these benefits do not persist over time if that's the only treatment used. In this combined condition, we might have expected the best of both worlds, quicker benefits from medication and longer lasting benefits from CBT. And for some patients that's what happened, but for others, maybe those who tended to attribute their initial sleep improvements to the medication and not invest as much as their time in changing sleep habits, sleep beliefs, then when the medication was stopped after 8 weeks, then these people were clearly at greater risk for relapse. One other study here where we can look at the speed and the trajectory of changes when we look at CBT used alone versus CBT plus zolpidem. You can see that regardless of the dependent variables we looked at, these are the first 2 weeks, so that's baseline. This is the first 2 weeks of treatment, and this is the end of treatment. And it's the same pattern for all dependent variables. Clearly, the addition of zolpidem to CBT strengthen the initial benefits. You can see that it produces a greater decrease of sleep latency or wake after sleep onset, and a greater increase of sleep efficiency, particularly in the first 2 weeks of treatment. But when we look at the end of treatment, week 5 and 6, we can see that essentially the 2 treatment conditions were about equivalent. So Yes, the medication may provide an added value initially, but by the time we reach the 6th or 7th week of treatment, the benefits are equivalent whether we use CBT alone or CBT with medication. We have another study also. I'm not going to present the results here, but it's along the same lines. So what this is telling us is that if you decide to combine medication with CBT initially, which may not be a bad practice, it's very important to plan a supervised tapering of the medication by the time the patient has reached maybe the 8th or 10th week of treatment. You don't want to keep your patients long-term on the medication unless they are comorbid psychiatric or medical conditions. But even then, I think you should always make sure that CBT is also implemented in parallel. This is a more recent study that was published in JAMA Psychiatry, where we look at sequential therapies for insomnia. So what we did here, we compared the behavior therapy, so that was a sleep restriction, stimulus control, compared to zolpidem. And the initial, the first stage of therapy lasted 6 weeks. And we are reporting the results here in terms of response and remission based on scores obtained on the Insomnia Severity Index. And we can see here that there was not much difference between behavior therapy or zolpidem during the initial 6 week of therapy. But there was a trend for behavior therapy to produce better response, higher response, and higher remission rates compared to zolpidem. The next thing we did is, among those who did not achieve remission after the first stage therapy, then we offered them a second therapy. So we can see here that those who received BT and did not remit with the initial treatment were re-randomized for a second stage of 6-week additional therapy of zolpidem or cognitive therapy. And we can see that there was definitely an added value to add a second treatment component to these people who did not reach remission. And we have again the percentage of patients who had a response and the percentage of patients who achieved remission with the second treatment. And the same here for those who went from BT to CT. So from a 45 to 50% response rate, we went to a 62 to nearly 70% remission rate. And among those who received zolpidem, the added value of a second treatment component was not as clear as with those with behavior therapy. So the sample size was larger here, and the interesting thing about this study is that we also look at patients who had comorbid mood and anxiety disorders and look at their treatment trajectories. And this is what we have here. Among those 74 patients with comorbid mood or anxiety disorders, what we found in the results is that after the initial therapy, that's post-1, with BT or zolpidem, there was a significantly lower response rates among patients with psychiatric comorbidity. So the response rates was 36% versus 54% for those who didn't have a psychiatric comorbidity. Now, when we look at post-2, that's after the second stage therapy, we had a very interesting finding. It's based on a small sample here, but still, there was a higher response rates among patients with psychiatric comorbidity, but specifically among patients who received as a second stage therapy either cognitive therapy or trazodone. So why might that be? Initially, the first two therapy, behavior therapy and zolpidem, are very sleep-focused, sleep-specific, whereas trazodone is an antidepressant And cognitive therapy goes beyond sleep when restructuring dysfunctional beliefs. So there is probably a transdiagnostic generalization when you use these agents, cognitive therapy or trazodone, specifically among patients who have a comorbid psychiatric disorder. So you can see both sequence BT who switched to CT, that's the square, BT to CT, and those who went from zolpidem to trazodone, the square, had both higher response and remission rates at post-2 as well as at follow-ups than those who went from BT to zolpidem or from zolpidem to BT. So I think that's a very interesting finding that needs replication. So what can we say about these results? First, BT and medication produce equivalent response and remission rates as initial therapies for insomnia disorder, but the addition of a second stage treatment with either CT or medication was beneficial for those who did not remit after first stage therapy. So this is really an indication that, well, we know that there's no treatment that works for all patients, and that we need to develop treatment algorithms that will improve outcome, particularly in patients with specific phenotypes involving psychiatric comorbidity or other forms of phenotypes. So the last few comments I want to make about CBT is, even if it's been shown very effective for treating chronic insomnia, it doesn't work for everyone, and it's not available in many clinical settings. So over the last decade, what we have seen is an increased pressure to package CBT so that it can be delivered more efficiently by non-sleep specialists. So the question is, technology the solution to that? Certainly you're well aware of all these web-based treatments that are now available for insomnia and many other conditions. There are multiple apps available in the market also to improve sleep. So clearly we are now in this era, moving from face-to-face to telehealth to digital therapeutics. I've worked with colleagues at the University of Virginia to develop a program that is called Shut-Eye, and now that has been commercialized as Somrest, and there are others as well, as, for instance, Sleep Coach and Sleepio. So there are different programs validated, but only a few, I should say, and that's the problem. Now the question is, are those internet-based CBTI programs, are they as effective as CBTI implemented face-to-face? Well, there's a meta-analysis that has looked at the efficacy of internet-based CBTI. And these are the individual studies here. These are the effect size. So by and large, we can see, and this is here, the data are based on the Insomnia Severity Index, and the bottom part is the same studies, but looking at sleep efficiency. So we can see that all these studies, it's not many, but about 10, did all produce positive effect size when using an internet-delivered CBTI. And that was true for the ISI and true for improving sleep efficiency. Treatment benefits were well sustained for sleep efficiency, and the Insomnia Severity Index had the mean follow-up duration of 6 weeks, but they were not maintained for sleep diary-derived variables like sleep latency, wake after sleep onset, and total sleep time. And I think the other point I would want to bring to your attention, look at the dropout rate, dropout or low completion rate. I think that's one of the main problems with the internet-based or digital therapeutics. Clearly, some of the benefits are that it makes treatment more readily accessible to users. It requires limited human resources. Some of these programs are quite inexpensive, but we have to keep in mind what the limitations are. Clearly, there's a higher attrition rate, so it's not always easy to engage patients in this program, and there's a risk of premature discontinuation. There's also limited opportunity for corrective feedback. Some programs have an interface that allows for some interaction, but others are simply static programs with no opportunities for corrective feedback. There's also a risk of inappropriate diagnosis of application of treatment. We know that many patients with sleep apnea may present with an insomnia complaint, so if they are not properly diagnosed at the beginning, then they may work for nothing to improve their sleep when the attention should focus on another sleep disorders. And the final point I would make is that most applications of program have not yet been tested with clinical patients in real clinical practice. So I think we're moving in that direction, and clearly there's a place for this kind of therapy, but I really don't think that this should be seen as a replacement of therapist-guided CBTI. Digital CBT is here to stay, and I think it fits well with a step care model for delivery of treatment, but we have to look at it as complementary rather than a replacement of face-to-face CBTI. So, in conclusion, I'd like to remind you that insomnia is a prevalent public health problem with negative impacts on physical, mental, and occupational health. There is strong evidence that CBT is effective, it produces sustained benefit, and it is well accepted by patients. It's also recognized by the scientific and professional community as first-line treatment for chronic insomnia. But unfortunately, I don't know how it is in Colombia, but in the rest of North America, and Canada and the United States, there's very limited financial support from public health authorities. And it's somewhat paradoxical because there is support to treat insomnia with medication, but because CBT is seen as taking more time, the financial support is not always there. And I think that's taking a very narrow view of this important clinical problems. But for the most part, we have to acknowledge that insomnia remains for the most part untreated, and CBT is underutilized by healthcare professionals. And there are still very important gaps between the evidence available supporting different treatment modalities and current treatment practices. So I hope this presentation will encourage you to use CBTI or to refer your patients to psychologists or maybe psychiatrists or other healthcare professionals who are trained in providing CBTI. And if we look at the future, clearly we need more research to validate optimal treatment algorithms with and without medication. And we'll need to look more closely at what should be our first treatment and what to do with non-responders. And the big question is, can we reverse morbidity among people with chronic insomnia? We also probably need to develop more personalized therapies based on patients' preferences, insomnia phenotypes, and initial treatment response. And along with the digital trends, I think that we clearly need further validation of these abbreviated treatment delivery models. And we need to educate our patients that it's not because it's available on the web that it's a valid and evidence-based approach to treating insomnia. On this, I want to thank you and acknowledge many of my colleagues who have contributed to the research that I presented in this lecture. And thank you for your attention.